Okay, well, good morning, and thank you all for being here. And I'm glad to present Dr. Jane Hankins. She comes all the way from Memphis, and we are happy to welcome her in Shreveport. I think this is her first time here. You know, we have a great relationship with St. Jude, as we are one of the 8 affiliates that work closely with St. Jude, whether in the oncology part or the hematology. And we are always looking forward for more collaboration with our staff in St. Jude's. Dr. Jane Hankins, originally from Brazil, actually was there when the recent Olympics were there. I envy her for that. And then she did her residency and fellowship in La Bonheur and St. Jude in Memphis and continued as staff there. She has more than 50 publications in sickle cell, so she's well versed in sickle cell. And she's now leading the effort about building a transitional program in St. Jude, working closely with the adult internists. And I'm glad Dr. Mills and Dr. Manzoor are here. Thank you for coming today. And I think this is a great effort and great collaborations that we wish the different departments to start working on. And so we have our own transition program. Well, I'm going to give the mic to Dr. Hankins, and thank you.
Can you hear me okay? Yeah. Well, good morning. Thank you. It's a great pleasure to be here. Thank you, Dr. Jude, Dr. Kalanis, and Diana for the great reception and hospitality. Thanks for the crawfish last night. Can't come to Louisiana if I don't have crawfish. So great pleasure to be here. And I am going to share with you some of the work that we've done with our adolescent clinic for sickle cell disease and our young adult program. A lot of what I'm going to talk about can be applied to other chronic diseases. At the very end, I will show you how we are taking this program to the next level and layer research on top of it for sickle cell disease specifically. So the very end is more specific for sickle cell disease, but the beginning, the principles can be translated to other chronic diseases of congenital cardiac disease, CF, and a lot of the principles can be applied. So I have no conflicts to disclose. I do have funding that I have to disclose from HRSA and our ALSEC, which is the fundraising arm of St. Jude that helps support most of this work. So I am going to review the trends of survival in sickle cell disease, which is the basis for why we are where we are today with the children surviving into adulthood, what we are in the transition to adult care in sickle cell disease today, the American Academy of Pediatrics recommendations to transition, and then what we've done in Memphis to help the transition to adult care and where we are going from here after now that the program is maturing, and what's the next step. So the problem of, not really a problem, but where we are today with transition to adult care pertains to all the children with special health care needs because we are doing such a good job treating our kids, they're becoming adults. So the estimation is that approximately 20% of the adults, of the adolescents today in the United States will have some kind of special health care needs. And that will demand more on the system and more than routine health, so more specialized care as they reach adulthood. And survival rates are increasing, and the numbers are estimated at 750,000 adolescents who become legal adults every year. They turn 18 and become adults. It's a huge number. So obviously, having a successful planning in place that this young adults now can be absorbed and receive specialized care as they were receiving in children is really important. Several of the societies have issued statements highlighting this trend of survival and the need for more specialized care as they become adults. And now these policies and statements are over 10 years old. So the American Academy of Pediatrics in 2002 said this is something we have to be paying attention. We have to provide the critical first steps to implement a successful transition program And in 2003, the Society of Adolescent Medicine said the same thing. So people have been thinking about that for a long time, and different societies, and it's just taking a little while for things to get traction, and these programs have to be put in place. Specifically for sickle cell disease, we've done a great job with our kids. So if you look at survival in the 70s and then in the early 2000s and more recent years, the survival of children has really improved. This is mortality in the 70s, and we really were able to squash the mortality of children with sickle cell disease today. And then if you look at now the mortality as kids are getting older and becoming adults, what changed from the 70s to the present date is that we've pushed the time when they start dying a little bit later. So instead of start dying in the mid-teenager years, now they start dying as young adults. So that coincides with the time when they leave pediatric care and go to adult care. Unfortunately, if you look at this curve here, this is in the 70s and this is in the 2000s. Nothing has changed in terms of how often and how much the adults are dying. They're probably dying even more they did 20, 30 years ago. So this is not good. All we did was just delay when those things happen. And not only they are dying more, but they are utilizing the health system in an incorrect way. So this is the famous report that is now 6 years old by David Russo that talked about the emergency department visits and inpatient stays of all patients with sickle cell disease and only SS disease, and he sectioned by different age groups in approximately 7 to 10 year intervals. And he found out that the 18 to 30-year-olds are the ones who utilize the health system. They go to the emergency department, they admitted to the hospital more than any other age group in the sample. This is an administrative data set with Medicaid, but this is probably reflective of what we have in our clinics. So 18 to 30-year-olds, that's when they use the medical health system in the incorrect way more often. And not only that, that's also the age when their health is deteriorating in general. That's when you start seeing organ dysfunction more frequently. That's when you start seeing more proteinuria, heart dysfunction, more diastolic dysfunction, when you start seeing more chronic pain and lung dysfunction. So it's almost like a perfect storm, right? So the undesired outcomes really become very evident as they go from adolescence to adulthood. So I think it is not one cause of it. I think it's a combination of factors why the disease deteriorates as they become adults. I think it's a combination of social behavior factors, and those are individual, personal factors from the patients. They're not prepared, not engaged enough in their care, and they need special attention to learn how to become adults and get trained to do that. The health system is broken in many cases. I think there's a lot of effort to try to improve that. We are doing a lot in Memphis to try to improve the health system to absorb the young adults. I know a lot is done here. And then the biology of the disease. We know it gets worse. We know as they become adults, as I said, organ dysfunction becomes more evident. So to address all these three broad reasons for why the disease gets more severe, we've been spending a lot of time developing the transition to adult care program, and also to address the biology of the disease to understand why is that the disease itself, the organ dysfunctions, worsen as they become adults. We've been working on a natural history study for sickle cell disease, which is called SCCRIP, and I'll talk about that at the end. So if you look at the barriers to transition from the adolescent standpoint, this is something that we hear over and over, right? I don't want to leave the pediatric care, and I hear that every day. I don't want to go, I don't want to go. But they have to go, right? They are becoming adults. But they say, you know, I don't feel prepared. And one of the things that is frequently reported by the adolescents is that I don't know if I will be able to trust my adult providers as I trust my pediatric providers. So this is reported by the patients. And in a survey of 45 pediatric sickle cell programs in the U.S. a few years ago by Amy Svoboda, she found that the time when the patients were being transitioned to adult care varied around the different programs, 18 to 22. Only 60% of the centers actually had adult hematologists receiving these patients. A lot of the programs did not have adult hematologists and head internists that were trained to see sickle cell disease. And a lot of the, and 30% of the pediatric programs just kept the patients indefinitely. But one of the common things that, a very common thing that was reported in this survey is that the greatest barrier was to identify an adult provider who will be willing to receive this patient. So this is a huge barrier today. And from the adult standpoint, what are they saying about what are the difficulties that they had when they were going from pediatric to adult care? So then the issue becomes a lot more complex, right? Because now they're adults. Now you throw in the issue of insurance. They may have had coverage as children, but now they lose as they become adults. Some of them are not able to retain employment, and they're applying for disability. And then the issue of physician mistrust, especially when they need to utilize the emergency department, is a huge and very recurring factor when you interview adults. So it just becomes more complex. But if I were to summarize the barriers, the main barriers today to transition to adult care, I would say loss of insurance coverage, because we'll really limit the type of adult providers who will accept this patient, lack of interested adult providers, lack of adult comprehensive sickle cell programs. We have many more pediatric comprehensive sickle cell programs than we have adult sickle cell programs, and that's definitely something that needs to change. And then misconceptions by the healthcare providers, that's both on the pediatric and on the adult side. And then the teenagers' unpreparedness to become adults, to leave the pediatric program. They don't want to go, and they don't feel prepared to go. So we start thinking about all of that, and also keeping in mind that they're not matured. You know, these are children. You transition an 18-year-old, it's still a child, a legal adult who is not myelinated completely. So we do have to keep that in mind as you prepare. And transition should not end at 18. Transition continues after 18 because of this. So you need to continue working and planning, and just after they cross to the adult side, you have to continue your program of transition to adult care. And as an example is that if you do that, if you educate, they will learn. So this is just an example of Duke University that you did a pilot study with a small number of adolescents that they spent time in clinic with a notebook, and they taught disease gave education, disease complications, management skills, a lot of different issues of becoming an adult, sexual development and behavior, independent living, racial identity, academic and vocation pursuits. And then what they found is that, which is kind of intuitive, if you teach, then your scores before and after the education sessions will improve. So, proof of principle, if you spend your time, it's worth it. So we started thinking about all of that and looking at the literature, and we, years ago, we started putting it all together and developing our own transition to adult care program. And this is something that we decided that we needed to have this something called the triple aim of healthcare. So we have to pay attention to three things. We wanted to make an impact on the patient himself. We wanted him to think that the experience during the transition from pediatric to adult care was meaningful. We wanted this to impact the population in general. We thought if we impacted the patients individually as a group, there would be a bigger impact. And also impact in the system. We were hoping that there will be an impact to decrease costs as the healthcare utilization decreased. So we began our journey developing and working on the sickle cell transition to adult care program. And when we started, that's what we looked like. We had the infant and toddler clinic, the school age clinic, and the adolescent clinic. We have large numbers. We are now close to about 900 children from 0 to 18. But we stopped it here, and we didn't have much of a relationship with the adult program, so we decided to focus on the preparation of the child. And the way we conceptualized transition wasn't only in the adolescent years when you're 17 and next year you're going to transition. We said, the preparation needs to start early. So we start thinking about your transition from birth. So you're transitioning from being an infant and toddler to becoming a school-age child, and from a school-age child to becoming an adolescent. Then it became easier for us to conceptualize the next step. Then you become a young adult and an older adult. So that's what we did. We sat down and we looked at the literature. We thought about the big principles. We looked at the statements from the American Academy of Pediatric. And as a team, which I'll show you who's on this team, it really takes a village to do this, I have to say. We started thinking, what does a child need to be prepared to go to adult care? What does a young adult need to have in place to stabilize the transition to adult care? So this is our map of transition from pediatric to adult care, and I'll be happy to share. It's hard to read, but I just wanted to give you this 30,000-foot view of the program, which we have the transition from early ages until adolescent years, and then we intensify from 12 to 25 what we do to prepare and stabilize transition to adult care. So we have several different things. We do genetic counseling. We train the adolescents to fill out the personal health record. I won't have time to show the results of every single thing that we do, but I'll show you the most significant ones. But the message here is, we thought about what every age and what we had to implement based on developmentally appropriate steps. And then as young adults, what were things that needed to be in place. And this is something that we used a lot. These are recommendations that are based on the American Academy of Pediatric principles, but they were very well articulated by this group who developed this website called gottransition.org, which I do recommend everybody interested in transition to adult care visit this website. Lots of resources. But what they did is they took what the American Academy of Pediatrics said it needed to be in place, and they translated into more or less our map looks like, but with more details. In the beginning as you're planning transition, you need to have a transition policy. And then you have to track and monitor your progress. And then you have to measure readiness. And this continues. It's just part of the table. And then on the adult side, what should be done, they come to the adult side, so they have a transition policy that says, okay, now you're an adult. This is how we're going to treat you. And then if they happen to not leave pediatric care, you do have to modify the treatment to treat these patients as adults. A lot of the clinics, family practice clinics, for example, they don't really physically transition the patients, but they have to adapt the way they treat these patients. So these are nice guidelines that can be followed as you start to prepare and then treat the patients as they're becoming adults. So to simplify what this table says is that the first thing that you have to do and that can vary, at what point you start talking about transition, you have to develop something called a transition policy. We begin at 12. At 12 years of age, we hand the policy and we discuss the policy and say when you're 12. At 18, we're going to transition you to adult care. We're going to prepare you over the next 6 years. So that discussion begins at 12 with the child and the parent. And then we track and follow. We have a database that we monitor who are our patients, and then checklists of the progress and that correspond to our map. And then we measure the readiness along the way. So how are you progressing? Are you learning what you have to learn? How is your health? How is your quality of life? And then we have concrete planning when it starts getting closer to the time that we define in our program at 18. Some people define at other ages. So let's think about what adult provider that you want to go and cover topics that are specific for transition. For example, do not lose your insurance coverage, or the steps that you have to take to maintain your coverage. And then we do the transfer. So transfer and transition are different things. Transition is the whole process of going from a child to an adult, and the transfer is the moment that you actually go. So that's when we make the appointment, we send the records, and then after you complete the transfer, you close the loop within 3 to 6 months The American Academy of Pediatrics recommends that after the child with special health care needs leaves pediatric care, that they establish care within 3 months, 3 to 6 months, which sometimes can be a longer period of time without seeing a provider. If I were to simplify it even more, I would say between 12 and 18 for our program is 18. Some are 20, 22, 23. We prepare and plan. The moment of handoff for us is 18. Then that's when we send the records, we make the appointment, we make sure that the patient does fulfill that first appointment, and then we close the loop and we continue working with this young adult. And I'll show you what we're doing on this side between 18 and 25. So how do we do that on a daily basis? So we have the big map, and now we break down and we operationalize in the clinic on a day-to-day basis using this that we call the plan of care. And this we have from birth to 25. So what is the plan of care? The plan of care is just a table, a checklist. That list is everything that should happen to the patient based on the age. So this is an example of the plan of care between 6 and 7. We have one of those for every 6-month period from 0 to 25. I'd be happy to share. So the patient is between 6 and 7 and comes to clinic, gets these labs, these shots, sees the nurse case manager who would discuss these topics. The nurse practitioner or the physician would discuss these topics, would do these things, TCD, education, social worker, child life, so it's spelled out. And this corresponds to our orders in our EMR. We use Cerner. What do you use here for EMR? Epic. Okay, I'm sure and I know Epic can do that. So in our EMR, which is Cerner, we have what we call the power plans. The power plans look exactly like this. I just have a box here that I click by age. And this is a plan of care for a teenager, 13 or 14, and look at the topics here change. So we talk about sexuality, alcohol, illicit drugs. So this will morph into what an adult should know slowly and gradually. And this is our team. We do have patient care, and as I said, it does take a village because, as I said, in that table, it's a multi-specialty clinic, right? So it is interdisciplinary care, which is a little bit different than multidisciplinary care. Interdisciplinary care is everybody's together in clinic, and we all work. We have our own areas of expertise, and we work as a team at the same time in clinic, seeing the patient on the same day. Different than today, I see the hematologist, tomorrow I'll see the cardiologist, the day after tomorrow I'll see the pulmonologist or the social worker. So it's all together, it's coordinated. So this is what we have. On any given day, if they come, and it's about once every 6 months when those big visits happen, they will see a lot of us in clinic. And then our program really focuses on education. So the first part, right, the preparation of the adolescent. How do you help this adolescent become an adult? So we focus a lot of disease education or health literacy, disease-specific health literacy. We teach about what sickle cell disease is, what are the consequences for your body, how do you manage the complications, how do you recognize the complications. We've developed material and literature that is geared towards the child and then the adolescent. Again, we'll be happy to share. We do genetic counseling to the adolescents, and then we teach them how to fill out the personal medical history. So the same thing that we do when we go to an adult physician for the first time, that we fill out the long questionnaire, right? What problems have you had? What medications do you take? Have you had surgeries? Do you have allergies? We found out that our adolescents had no idea how to list the problems that they have had, and some of them had pretty significant past medical history. So we spend time teaching them. We have a mock personal medical history module that we teach them how to do it. So this is just an example of some of our literature that is geared towards the adolescent. This is a specific one that discusses going from pediatric to adult care. We have one about alcohol, tobacco. This is a genetic counseling one. This is about sexuality. Now, every educational material that we develop, every module of education is paired with the measurement of knowledge gained. So everything we do, we measure, because we don't want to continue doing something in a clinic that doesn't work. So it's almost like doing quality improvement on a daily basis. So we test, and if there's no improvement, then we drop that. So it's an ongoing process. So this is just an example of, as we teach about sickle cell disease, then we apply this questionnaire before the educational session happens and right after the educational session happens in clinic. And then the nice thing about it is that we keep that score in our database, and then we can write abstracts and write publications and show, okay, we're really making an impact in the education and health literacy of our population. And then we have emphasis too in our program on patient activation and engagement. We pay a lot of attention to medication adherence, a huge problem, right? As you're a child and you become an adolescent, a lot of the good adherence rates that you had as a younger child goes away. And a lot of that is because the parents sometimes take a step back, which they should, and the child doesn't assume the role of taking that medication. So but we really have to connect with the adolescent, right? The adolescent really needs to see the importance and needs to buy into the taking my medication. So a few years ago, I was in clinic seeing this 15-year-old, and I was talking to him, and he was on the phone texting. And I really got frustrated because he was giving me no attention at all. Right? Seems familiar, right? And I was really like trying to talk about hydroxyurea and your disease, and I got nowhere with him. So I said, "What's your phone number?" And he looked at me and said, "Why?" I said, "Well, just give me a phone number." So he gave me his phone number. I stepped out of the room and I texted him. I said, "What about your hydroxy?" And he texted me back, and then the light bulb went off. Okay, well, that's how I have to talk to them. So I went to the IT people and I said, "Can you develop a text message application that will go out of the server, cannot come out of my cell phone, and I can actually talk to the patients and remind them of the medication?" So that's what we did, and then we started using that in the clinic, which I found out that a text message application is pretty easy to develop. So we took that to the clinic, and here's what the key was to use this. We asked the adolescents to write the message to their best friends or their girlfriend, their boyfriend, because if the message from the server went like, "Take your medicine today, take your medicine 3 times a day, take your medicine once a day," they would ignore it, right? So what we do is, when we're in clinic, we said, if you were to text your best friend, your girlfriend, your boyfriend, what would you say? And sometimes the messages begin with, "Hey, take your medicine." I said, no, really, like, you're texting your friend, and they go, "Oh," I would say, "Yo, then take your med." I was like, "Yeah, exactly this." So then it would start programming the message to come out exactly the way they said, and some of them were really, really funny, but then it started working. Then we went back and we measured their adherence, and we actually used the fetal hemoglobin increase. And these were adolescents who were already on hydroxyurea, had been on hydroxyurea for years, and you can clearly see the adherence going down, right? The MCV going down, the fetal hemoglobin dropping, and then they started the text message, and if they change the medication possession ratio, which is just a surrogate for adherence, this is how many drugs or how many pills from the dispensation date to the next dispensation date in a, say, 30-day period, right? If it's a medication that you dispense once a month. So you dispense 30 pills to last 30 days. So between one dispensation and the next dispensation, how many days went by? So if it's more than 30 days that took for the patient to fill a 30-day prescription, again, say it took 60 days, then the NPR is just 50%. So we calculated this because we should dispense hydroxyurea once a month. And if the NPR improved, so did your fetal hemoglobin. So it works. So we were very happy about that, and we were lucky to apply for a grant that actually will let us take it to the next step. We are now trying to understand among adolescents and young adults what are all the levels of barriers that do not allow this adolescent to take hydroxyurea or this young adult to take hydroxyurea. So this here on the right just shows the size of the problem. This from Medicaid claims data around the country. So over 8,000 adults who have sickle cell disease and should be on hydroxyurea, less than half are prescribed the drug, and a very small number of them actually take the drug with good adherence. So we were lucky, and we got this grant, and what we're doing now, after we understand all the barriers, we're going to develop an app that not only reminds the patients to take hydroxyurea, but will have other functions such as education online, connection with other patients, and motivational cues to help the patients take hydroxyurea better. So this is all patient engagement. So this is an NIH grant that we receive, and we hope to test this on a large scale after we tested it in Memphis. So after you spent your time preparing the adolescent to transition to adult care, now you have to track progress. Are they learning, and are they getting ready to move to adult care? So the issue is when to transition is very important. We use the age 18, but in reality, not every adolescent is ready to transition to adult care at age 18, right? So we think about that in different domains. So you have to be ready psychosocially, emotionally, vocationally, and medically. We've held patients who were not ready, and we intensified depending on which domain that we thought was more deficient for that particular patient. There are different scales and checklists that you can use to measure readiness. There is this one that was just endorsed by the American Society of Hematology. This is more specific for sickle cell disease. The first one that is really specific for sickle cell disease to measure transition readiness. It's available on our ASH website, but it's to be used at several different time points as the child is ready to go into adult care. So the recommendation here is that you apply this checklist that says things like, I know what type of sickle cell disease I have. So the patient says yes or no. I know my medical needs and can explain them to someone. And of course, this is the patient filling it out, right? So, but if there's honesty, and then you can track this over time. So the recommendation is that you apply this somewhere around 12, 13, and then again at 16, 17. And then as adults, you apply this again because you kind of have a sense for how is the trajectory of this patient. Is the patient acquiring and getting the knowledge and getting ready to transition? So, and then in our program, as the patients go, the transfer moment, right? What kind of interventions we have for that specific time point? We have something called the Transition Tour program in Memphis. And for this, what we do is around 17 and a half years of age, we invite the adolescents to visit the adult providers in Memphis. So they come to St. Jude, and we have a bus that takes them to the adult providers in Memphis. And there are 2 comprehensive centers that they visit. So they visit both. It takes a half a day. They come back to St. Jude at lunchtime, and then we have lunch with them, and we discuss what they liked and didn't like about what they saw, the adult programs. And that helps them visualize what are the options in the community and where they would like to go. So we give them the option. We don't tell them where you go for care. We say, here are the 2 comprehensive programs. We're lucky to have 2 in Memphis. There are private practice clinics who would take sickle cell disease, but will take you to the comprehensive centers that look more like the pediatric program, comprehensive care, interdisciplinary care. And then you think about where you want to go over the next 6 months. And then we went back and measured the results, the early results of this visit, this transition tour program. And what we found was that if the adolescents did participate on this half-a-day activity to take the time and go visit the adult providers, they were more likely to fulfill an appointment with the adult provider. And 1 year later, they were more likely to still stick with that adult provider than those who did not attend this tour. So this was very good, and I told you that we measure everything we do. So this is an example of how we measure an intervention that we introduced to the program. So we kept it because we think it's impactful, and we have very good feedback from the families and the patients who participate. So we continue doing that. We do this once every 4 months. We invite 17-and-a-half-year-olds, around 17-and-a-half years of age, to participate in this program. The other thing that is important for a program is to measure the transition, the success of transition, both on a personal and at a program level. So you want your program as a whole to show that you are making an impact in the population, right? That the patients in general are finding adult care and sticking with the adult provider. So the issue of defining a successful transition that you will use to measure the quality of your program is debatable. There is no consensus in the community as to what is considered successful transition. I am pulling the example from 2 recent publications that actually looked at this problem, or I'm sorry, this question of what am I going to define as a successful transition, and there is really no consensus. Some people think that should be the number of emergency department visits before and after they went to adult care. Some think it's just establishing care, just attending the first visit within 3 to 6 months after leaving pediatric care. Some think it's just don't get lost, don't have a lost to follow-up case. Some people think it's quality of life. Keep the quality of life that is self-reported before and after adult care. Don't allow it to decline. So, this is not defined. We have been using primarily the fulfillment of the appointment with the adult provider in the past, within 3 months from leaving pediatric care. We're also tracking quality of life, but I haven't gone back and looked at the data yet because I don't have enough numbers on the adult side. But we think that this is an important marker of not allowing your patients to get lost as they leave pediatric care. And this is a significant change from where we started. Our transition to adult care program started in 2007 when the majority of our patients were getting lost. They were leaving pediatric care and disappearing. And today we have a placement rate of 93%. So we lose less than 10% of our patients, which is really good considering where we started. But it's not where I want it to be. And what we're looking now is we're looking at trying to understand why are we still losing patients? Why are we still having patients who abandon care? And we're finding things like they show there are early signs of I'm going to abandon care. They start missing a lot of appointments at adolescents, and there are other factors they're still understanding. But these are patients who either right before they turn 18 or after they complete the last visit on the pediatric side, they just don't show up for the first adult visit. So we're really spending more time here to make this number 100%. We may never get there, but we're trying to. And these are the patients who later on end up being the high utilizers of the system, visiting the emergency, unfortunately, visiting the emergency department a lot and costing a lot to the system. So, but we were able to prevent that number from being very high. So then after they go to adult care, what are we doing? So this is newer. So this, what I'm going to show you are more recent investments of our program and in partnership with the adult program that we have in Memphis, one of the 2 comprehensive programs. It's at the Methodist University Hospital. We've been very fortunate to collaborate and partner with them. And we developed something called the Transition Clinic in partnership with the adult program. What it is a clinic that is specific for 18 to 12-year-olds, and it happens on the adult side. And the way we do is that we have what we call the co-location of providers. So the pediatric providers travel to the adult clinic, and in the beginning, we would spend once a month, 1 day a month. We would go. I went there and spent a whole day once a month with the adult provider, and I brought my nurse with me, the nurse case manager, And we saw the patients together. So in the same visit, the patient would see two providers, the pediatric and the adult provider. And that was designed to be between 18 and 25. So multiple times during 18 and 25, they would see me and the adult provider. And then the nurse case manager, I thought that was a good idea to have this overlap of care, having people who travel between the pediatric and the adult side. And back then I couldn't spend a whole lot of time on the adult side, so I let my nurse spend 50% of her time on the adult side. And the way we designed is between 17 and 18, she would case manage on the pediatric side, and between 18 and 25, she would case manage on the adult side. So she spent 2.5 days per week at St. Jude and 2.5 days a week at Methodist. And that turned out to be really good for the patients because they felt really comfortable seeing the same providers on a regular basis, and they really like to see the same nurse on both sides. And these are the early results of that clinic. This is the publication that I showed you in the beginning by David Brousseau, of patients 18 to 30 years of age who use the healthcare system in the adequate way, right? More emergency department visits, more admissions to the hospital. And we compare our results the first 2 years of this transition clinic, and we saw that they did have more or less the same number of emergency department visits, but they weren't admitted as much. So that was good for us to see. So healthcare utilization did decline. And some of these acute care visits weren't just emergency department. Some of them were coming to the clinic as a walk-in for pain treatment, for IV fluids, for an infusion visit. So this is what we have today because of the partnership with the adult hospital Methodist. We do have a better continuum of care, and we have the transition that goes, that moves from every step of the way from birth until you become an adult. And because of that, because we have this program now that is laid out and we are able to keep the patients in the system, abandonment of care is low today, we're able to follow these patients longitudinally and now add research to our, different kind of research to what we're doing in transition to adult care. So we developed this natural history study, and the reason that is important to do that is because as I understand how children become adults, risk prediction of organ dysfunction, for example, if I'm able to understand and pick up early signs of who is going to develop proteinuria and renal dysfunction later on, or heart dysfunction, or lung dysfunction, then I can come back and institute screening methodology early as children, and hopefully intervene earlier and prevent early organ dysfunction as young adults. So this is the study. It's called SCRIP, Sickle Cell Clinical Research and Intervention Program. It's a lifetime natural history study, and we are also collecting biological samples. So it's allowing us to do DNA sequencing of the patients and correlate with the phenotype, so genotype, phenotype studies. And we are looking at incidence and prevalence and severity of the disease complications in every stage of the development. We're hoping to identify risk factors for premature mortality and organ dysfunction. Some of those patients are on hydroxyurea transfusions, so we hope to understand the effect of the disease-modifying therapies on growth and organ dysfunction, and keep understanding what we're doing to prepare and maintain this patient in the system to continue receiving preventative treatment, healthcare maintenance visits, so the functional aspects of our transition to adult care program. And this is what we do on this longitudinal natural history study. Doesn't matter where we enroll the patients, we'll collect data prospectively, but we also open the charts and collect whatever is available from the chart. And it's a very comprehensive amount of data that we collect. We are collecting blood tests, but also anatomical MRI, cognition tests, which we are doing systematically. We do neurocognitive function assessment on all our patients. Lung function, we do PFTs, and here you can see the breadth of the data collection. And to be honest, all of those things that we do anyway for clinical care. And again, on that plan of care, it's listed, each age, what we do. So at a certain age, I do an eye exam or a pulmonary function test or cognitive function. So those things we're doing for clinical care, but now we're collecting and adding and depositing in a database of the study so I can go back and analyze. Our enrollment has been very successful. We currently have St. Jude, Methodist, Baton Rouge, Charlotte, and the Peoria affiliates are participating. We are now close to 150 patients participating in this study. And this closes the loop. I explained to you now how we are addressing the health system because we are partnering for the adult program. We take the patients to visit the available programs in Memphis. We're spending a lot of time preparing the patients to transition to adult care. And now we're trying to understand the biology by layering the natural history study on our transition to adult care program. So in conclusion, survival in sickle cell disease and other populations with special health care needs is increasing. We need better methods to improve the transition process from pediatric to adult care. Careful development of the transition programs is very important and always measure all the interventions that you institute. And if you have a functional transition care to adult care program, that facilitates longitudinal research tremendously. So here are the resources that I will give it to you. We have a lot of the material for the transition to adult care program posted. The literature that we developed. This is the website that I said that I recommend you visiting, gottransition.org. And we do have, we developed a transition curriculum funded by HRSA, the Healthcare Resources Administration, through a grant that is available online that also details all the things that are recommended to be in place along the way as you go from pediatric to adult care. So with that, I thank you for listening, for inviting me to speak, and I'll be happy to take questions. Thank you. Question in the back.
Has anyone ever looked at the use of med-peds doctors that are trained in HEMONC to do the transition?
That's a great question, and I'm looking for one if you want to look at that job. So I think that it is really ideal. So you have to have a med-peds background, right? And you also have to have training in adult and pediatrics in HEMONC. I'm not sure that the adult hematologists are here, and HEMONC here. Is there any combined adult pediatric HEMONC program? I don't think there is, right? Yeah. Unless if you do something like this person here did, which would take a lot longer. When I was in Brazil, I did internal medicine and adult HEMONC, and I came to the US and did pediatrics and peds HEMONC. Unless if you want to spend 50 years doing that, you can. But I know people who are med-peds trained and then did peds HEMONC are now doing adult care, adult sickle cell disease. I am doing adult sickle cell disease. Now, I didn't tell you this, but after spending 4 years in a transition clinic once a month, now I completely flipped to the adult side, and I spend 60 to 80% of my time on the adult side, seeing the adult patients, and 20 to 30, 40% on the pediatric side, seeing the children. And that's just a temporary thing because I cannot find a person like you're describing to lead the adult program.
On your first couple of slides, you showed a survival where the death during childhood went down.
Right.
And then you showed the bell-shaped curve.
Right.
Now, was that just SS and S beta thal 0, or did that include SC and S beta thal plus as well?
That includes all the genotypes, all sickle cell disease subtypes. Mm-hmm. Yeah, that's a publication by Kathy Hessel. She used public data sets from the CDC, and the CDC did not divide by genotypes.
So I'll tell you in the adult clinic, and I think it's the biggest problem for adult patients, is that a large number of patients have chronic severe bone damage, and we've collected the X-rays to document it in a lot of patients. And they need chronic opiates, and it's a problem. There's a trust problem in in the medical community in general, but particularly now with the federal government having a big push about opiates in, quote, non-malignant conditions, I can see that it's getting worse. That's a huge problem. Secondly, there are a lot of patients who do not have terribly abnormal x-rays. They're also taking a lot of pain medications. And you know, what I don't think has been addressed, and maybe, you know, it's a crazy quirk that I have, but when a patient has a condition where they're frequently exposed to very addictive opiates and they get addicted, well, you know, it's difficult to know, you know, the best way to approach that patient, because after all, they became addicted for reasons that were beyond their control. And every visit, the success of a visit and having the patient show up, at least listening to what we're trying to get across, depends on if they can get their pain medications. And I, for one, am not opposed to giving it to them, because I can't classify each patient and why some should have chronic opiates and some should not. So I let them more or less naturally select themselves. But I think that's probably the largest barrier to accepting adult patients with sickle cells into adult clinics.
Completely agree. I think that's a huge problem, and it's not going to get any better as far as legislations go, because we're now under the microscope how many prescriptions we write per month, right? But I do think, now that I am seeing more adults, I do think if you've seen one patient with chronic pain, you've seen one patient with chronic pain. I'm seeing patients who are addicted, and I have 2 of those, and they are homeless, and I'm trying now to convince them to stop going to the emergency department and come to the clinic, and we'll write the opioids, but we're going to rotate opioids to try to alleviate the addiction problem. I don't doubt that they're in pain, but I'm not sure using Percocet every day for 5 years is the best approach either. So now I'm offering rotation of opioids. I'm hiring a psychologist. I think if you don't address the psychosocial aspect of, you know, patient is homeless, the other one doesn't have custody of her child and jumps from family member to family member, a friend, a boyfriend's house, and not in a stable environment. So is depressed. I think that depression is a huge issue. A lot of the patients I see self-medicate with morphine and Percocet their depression. A lot of them have a central sensitization of their pain. It's very hard to treat. So now I'm trying to understand more, individualize the care. I don't think having a standardized treatment for pain will work. I think every patient will really have to be treated differently. My goal is to take them off of the chronic opioid dosage, but really it will be different for every patient. So I think for those who have central sensitization, we'll take a lot of things like behavior modification with a good psychologist who knows how to do it, support from social worker, and drugs such as pregabalin that I know are good for central sensitization, Lyrica, right? Unfortunately, not covered by many insurances, and gabapentin, and amitriptyline. So I think we have to get smarter using all those medications, and modifying the treatment. So I'm not opposed to doing exchange transfusion with hydroxyurea for a short period of time on those patients and try to, you know, force the sickle hemoglobin down. May or may not work. You know, works in some cases. So I think we have to use our armamentarium of how to combat chronic pain. But it's time-consuming. Those visits probably take 2 hours if we can get the patient there. And it's not only the physician seeing the patients. You do need this village around you to address all the aspects of why the patient ended up where they are. Right? You know, it's very complicated, very complex. It takes a lot of time. It takes a lot of money.
How many visits do you do with the adult hematologist before you turn the care over to them when you do the transition clinic?
0. They just visit. They don't have a true appointment. That's the way we do. They just have this tour. They go when they're 17. They visit. They choose where they want to go. They come back to the pediatric side, finish all the visits until they turn 18, and then they go to the adult care.
So you don't do a visit joined with the adult hematologist?
On the adult side. So I will. Oh, how many visits?
Yeah, how many do you do?
It's between 18 and 25, once every 6 months.
Okay.
So several.
Unless they are on Hydroxyurea.
Correct, or transfusions. Right. But then they won't see the pediatrician at any of those visits necessarily.
I like what you said. When you have pain, you don't keep giving them pain medicine. You have to find a resolution to it. I think the blood transfusion option, hydroxyurea option, or maybe psychiatrist option, or add another medication, not just even every time more and more pain medicine. They start with 1 pill first week, 10 weeks from now will be 10 pills a day. And then a few years later, we find them dead in Japan from drug overdose.
That's right.
I believe you should address every pain. If somebody frequent pain, tell me I'm in pain, I have to find a solution for your pain, not just give you pain medicine and tell you to go home.
And
Blood transfusion, hydroxyurea, psychiatry, education, and limited number of pills they have at home. Even we have to admit them more until we know they're sure they're not in pain, rather than give them white blanket of pills to take a pill.
Yeah, we're not helping that way. Yeah. The other thing is, if you're I forgot to say, if you're comfortable with methadone, that's something that. But you gotta be comfortable using methadone. I think she has a question in the back. Sorry.
We recently established a teen support group to assist with the transitioning, and it meets once a month. But I'm having trouble getting teens to attend. And with the transition, it does include a tour of our clinic, and eventually I hope to include a tour of the hospital on the adult side. I'm interested in what tools are you using to get your teens to participate in the transition tour?
It's the same problem we also have a teenager support group, so it's the same difficulty to get the adolescent attend the support group. But we were doing during the week in the evening, and the attendance wasn't good. Now we're doing on Saturday mornings, and the attendance improved a little bit. But the tour happens during the week because they need to see the clinic and the hospital when they're functional, right, activity. So a lot of people don't come, and I think unfortunately we can't convince everybody, but we try to sell it as this is really going to be helpful. Sometimes it resonates, sometimes it doesn't resonate.
Is there any positive feedback? Do you do any positive feedback?
We do. Right, so we show them that if you attend this tour, you're more likely to be successful in attending your visits to adult care. So in the past, and we show our prior results. We also say you will feel a lot more comfortable going to a place where you've already seen than just taking the airplane and landing in a different country without any idea of what you're going to find. So we try to kind of use those comparisons. But we have lunch. When they come back from the tour, we have lunch, and we discuss their visit, their day, but we also bring older people with sickle cell disease. And we like young adults who can connect to the adolescents. So that is good. So we say, you're going to have a lecture or spend time with an adult person who will talk to you. So that sometimes attracts the adolescents because multiple patients at the same time. Yeah, between 5 and 10. We transition about 30, 35 patients per year, so 5 and 10 attend the tour.
You can try to give them gift certificate, $50 for one person.
Well, we give lunch.
do you incorporate the parents into this?
Oh, gosh. It is a huge issue. I wish I could tell you that we've done more to prepare the parents to transition their kids to adult care, but unfortunately that's an area that we have not been able to devote too much time and effort, but yes, there is something that, and I keep telling our social workers that, let's think about something to prepare the parents, but yes, huge area.
Thank you all. Thank you.